afternoon, everyone. So, I'll be talking about fertility preservation as whole today. So, why this talk? Why we are talking about this? Increased incidence of cancer during the reproductive age. So, increasingly, we have been seeing that cases of cancer are rising, increasing in number as whole, and same in the reproductive age group, and same in the females. Survival and cure rates of cancers are improving. So we are living with reproductive age female patients having longer life after getting treatment. 1 in 1,000 adults is a survivor of childhood cancer, which is a huge number. Advances in diagnosis and treatment of cancers have led to high cure rate and longer survival. Nearly 1 in 12 cases detected before 40 years of age, which is a very young age. Survivors have to face infertility or early menopause. More females delaying motherhood to 30s and 40s, which we include under social oocyte freezing or social egg freezing. Oncofertility, when we are talking about fertility preservation in cancer patients, it becomes very important that it brings together oncologists and fertility specialists and hopes to provide real options to young population who undergo life preserving but fertility threatening treatment for cancers. The American Society of Clinical Oncology, ASCO, first published evidence-based clinical practice guidelines on fertility preservation in 2006, and an updated guideline was published in 2013. The goal of this 2018 guideline update is to provide current guidance regarding fertility preservation options for people with cancer anticipating treatment. People with cancer are interested in discussing fertility preservation, so the doctor must address the possibility of infertility before the treatment starts. So what happens generally when we diagnose, either we diagnose or it is diagnosed by some other specialist doctor, we always talk about the disease. We somewhere we forget, because cancer is a very strong word even in our minds, not only on the patient's mind. It is a very scary word. So sometimes, and earlier days, we used to forget about fertility. So we have been seeing increasing number of young patients, childhood patients getting cancers. So it is very important for us to start discussing about fertility preservation as soon as we get a patient of cancer, and as said, direct them to fertility specialists. Give whole range of fertility preservation options, as we say that cafeteria approach for contraception. The same thing should be given. At nobody no the patient, when they come to us, they have no idea how they are going to preserve their fertility, and they are not even thinking of that. So you have to expose them about the multiple options what we have, and we should counsel them along with psychological counselors, along with their treating doctors, to how to go for fertility preservation. Counsel patients along with the spouse, which is very wherever applicable. Refer patients to psychological providers, as I said, if distressed. Document the discussion on medical records. You have not written it, you have not done it. This thing, for any medical legal thing, it is very important. So you have discussed about the fertility options and fertility preservation options in the patient is very important to document in your papers. Patient and clinical communication. Healthcare providers can use the following points for a discussion of infertility and fertility preservation with the patient, or in case of a minor, it can be a guardian. Inform patient of individual risk, what kind of cancer it is, what kind of treatment they are going to get, how that kind of treatment will reduce their fertility. These things should be dealt in detail by the treating doctor and by the infertility specialist as well. Some cancer treatment can cause infertility or early menopause, as all of us know. Individual factors, this is very important: cancer type, what is the age when they were diagnosed with, they are diagnosed with cancer, treatment plan for every cancer or cancer patient will be different. So treatment plan should be very, very clear to them. High, medium, low, non-existent fertility status before cancer should also be discussed. That how the treatment is going to affect it, how the disease per se is going to affect it. It is very important for the practitioner, for the gynecologist, for different specialities to let them know their patients that how it is affecting their fertility. Coming to the options, as said, that there is female infertility, there is male infertility, then there is combined. So I'll be taking the first. It is not infertility, but we are preserving the fertility. So the very important option is cryopreservation of unfertilized oocytes, which is now we are doing very regularly. Embryo cryopreservation, we have been doing it since years now. Ovarian transposition, ovarian suppression, ovarian tissue cryopreservation and transplantation, conservative medical therapy, and conservative gynac surgeries. I'll be telling you the advantages and disadvantages. Cryopreservation of unfertilized oocytes. Cryopreservation of unfertilized oocyte, it is not done only for cancer patient. Social oocyte freezing, as I said, it is a very important part when we talk about cryopreservation of unfertilized oocyte. So um, um, when we are talking about social oocyte freezing is we are doing freezing just to save some years. The patient comes to you, she is in early 30s or late 30s, and we are advising them and she is not willing to be a mother right now. So you can advise them that you should freeze your egg. So I'll be telling you 2-3 important points about social oocyte freezing. Most importantly, the age when you should tell them when to freeze your eggs. So late 20s or early 30s is the age in Indian female. Whatever I'm talking is about Indian females. That late 20s and early 30s is the perfect time when you should ask them to come for social oocyte freezing. Now, why we are saying late 20s and early 30s? Because before that, if we are doing it in early age, like early 20s or before the age of 26, 27, then there are very high chances they can conceive later spontaneously. So the whole effort of preserving the effort and exercise and expenses to preserve that oocyte is not utilized. Why we are saying early 30s and not late 30s? All of you know sitting here that late 30s the number of eggs are very less, the quality of oocyte is not that great. So early 30s and late 20s are the best time to preserve your eggs. Now but practically the patients we are getting for social oocyte freezing, there are girls, there are females coming to us spontaneously after reading things, and they come to us generally when they are late 30s or early 40s. At that time, the number of eggs and quality of eggs both are not good, and in these cases we need to do more than one cycles. So it is very important for you to counsel them that you need at least 10 to 15 good number of 10 to 15 eggs to have a successful pregnancy later. Because at this age, when they come late 30s and early 40s, we are not getting very good number of eggs and very good quality of eggs. So you might have to counsel them for more than one cycle of oocyte cryopreservation. Coming back to the oncofertility, for patients who do not have a male partner, we should do cryopreservation of unfertilized oocytes. So very importantly, I want all of you to know that eggs are not as stable as embryos. So oocytes are the largest cell of the body, and preserving it causes some damage to it sometimes when you compare it with embryo. So embryo cryopreservation is much better than oocyte cryopreservation, but the fact is there should be a male partner. The second is, do not wish to use donor sperms. These days there are females, even married females, coming to us for oocyte cryopreservation. So it's not always that a married female will come to you only for embryo cryopreservation. So in those cases also, we should do oocyte cryopreservation. Have religious or ethical objections to embryo freezing. This is very important. There are communities and there are normal people also. They think that embryo is a live baby. Embryo, it is a baby. So they don't want to freeze that baby. For them, egg is a cell, but embryo is a microscopic baby. So there are restrictions in cultures. They don't want to freeze their embryo, but they are willing to freeze their eggs. So in that cases, in those cases also, oocyte cryopreservations are a very good option. Should be performed only in centers with necessary expertise. This is an important thing. But as a good thing to our IVF expertise in India and IVF labs in India, most of our standard centers are having oocyte cryopreservation facilities. Before 2012, it was also considered it was not considered as the perfect thing. It was considered experimental, but in 2012, ASRM said that it is not experimental. You should do it. Coming to the ovarian stimulation protocols, more flexible ovarian stimulation protocols for oocyte collection are now available. Timing of this procedure no longer depends on the menstrual cycle. This is a very important point when we are dealing with patients of cancer. Time is very, very important. Whenever a patient is, the patients we have been getting, they are diagnosed, the final diagnosis has come the other day, yesterday, and they come to us the very next day. So the counseling part is very, very important. Counseling by the person treating cancer, the person who has diagnosed the cancer, their timing is very, very important, because every increasing day can increase the invasiveness of the cancer, or the grades of the cancer, the stage of the cancer can enhance. So timing of this procedure, generally for IVF we used to, or oocyte collection also, we used to start with day 2, day 3 of the period, which in some cases we might even have to we had to wait for 20 days. But now we can start, there are flexible protocols where we can do start cycle at any day of the period. So as soon as a patient is diagnosed for cancer, she should be sent to the infertility specialist. Timing of this procedure, as I said, no longer depends on the menstrual cycle in most cases, and stimulation can be initiated with less delay compared with the old protocols where we had to wait for day 2, day 3 of the period. Thus, oocyte harvesting for the purpose of oocyte or embryo cryopreservation is now possible on a cycle day independent schedule. So there are different protocols which can be started at any point of time. Of special concern in estrogen sensitive breast and gynec malignancies. Generally, whenever we hear that it's in estrogen sensitive cancer, estrogen and progesterone sensitivity we check, estrogen sensitive breast or gynec malignancy, we get scared. So there are protocols now which can even given in these kind of patients. Estrogen sensitive breast and gynec malignancies, the possibility that these fertility preservation interventions as ovarian stimulation regimens that increases estrogen levels or subsequent pregnancy may increase the risk of cancer recurrence. These are treated with aromatase inhibitor based stimulation protocols. As all of us know, aromatase inhibitor decreases the estrogen levels in the body, and with this it has been easier for us to stimulate these females, getting when we are less apprehensive, now getting them stimulated. Studies do not indicate increased cancer recurrence risk as a result of aromatase inhibitor supplemented ovarian stimulation, and subsequent pregnancy. This also has given us some more confidence in stimulated estrogen sensitive malignant patients. Embryo cryopreservation, nothing more to say. It is almost like we do IVF for our patients. You don't have to do anything special for them. The only thing special now, as I said, that it can be started at any day of cycle is very important. So we, in cancer patients, is saving even 1 or 2 days very important. So it is an established fertility preservation method. It involves ovarian stimulation with gonadotropins, surgical oocyte retrieval, in vitro fertilization of oocyte and sperm in a lab, followed by freezing of all resulting embryos. So it is complete IVF. Only the embryo transfer is not done. Survival rate of thawed embryos is up to 90%, which is very high when we compared with oocyte survival. Implantation rate is up to 30%. Cumulative pregnancy rate is up to 60% in preserved embryos after the transfer later. So what are the disadvantages? Advantages, all of us know. Disadvantages, need of donor sperms when the patient is not married. That's where, and not married, or the female doesn't want sperm of the same partner, or or the partner also is suffering from something else. In those cases, oocyte cryopreservation we opt for, or the patient opts for generally. Need for IVF, that we know. Supraphysiological level of E2 unacceptable in estrogen sensitive malignancy. This was the concern earlier, but we have ameliorated it in a good amount now. Ovarian transposition. Ovarian transposition is offered when pelvic radiation is performed as cancer treatment. See, there are three basic modality of cancer treatment. These are surgery, radiation, or chemotherapy. So this is mainly given to the patients where pelvic radiation is supposed to be performed. Because of radiation scatter, ovaries are not always protected. It is strongly recommended in young girls needing radiotherapy. Because of the risk of the remigration of the ovaries, this procedure should be performed as close to the time of radiation treatment as possible. So it is very, when to give what is a very important point. As ma'am said that I'm not going in much detail, but you should know when to refer, what to do, and whom to refer. That is very important. So as I said, that we can start oocyte cryopreservation or embryo cryopreservation as soon as we get to know that the patient is suffering from a cancer, a specific cancer, and this is the staging. But in the case of ovarian transposition, oophoropexy, we need to send them, and we need to plan the procedure just before the radiation therapy will start. It is offered through laparoscopy or laparotomy, involves division of uteroovarian ligament and fixing ovary within the paracolic gutter, can be combined with cryopreservation of contralateral ovary. Both embryo and oocyte cryopreservation are established fertility preservation methods, and discuss the option of ovarian transposition or oophoropexy when pelvic radiation is performed as cancer treatment. Ovarian tissue cryopreservation, it does not require ovarian stimulation or sexual maturity. Sexual maturity is a very important thing. It can be done in patients, in kids, in children, prepubertal children. You can do ovarian tissue cryopreservation, but ovarian stimulation and, as I said, oocyte cryopreservation or embryo freezing can be done after puberty only, because before puberty they will not respond to our gonadotropin injections which we give for ovarian stimulation. may be the only method available in children. This method may also restore global ovarian function. So it's not only about preserving the eggs. Ovary has many other functions, many hormonal functions, many anti-aging functions. So it restores, it is a very, very important point that it restores global ovarian function. The only not great part is it is still considered experimental as of October 2012 by ASCO. Ovarian suppression. It is done with GnRH analogs. There is conflicting evidence to recommend ovarian suppression for fertility preservation. Recommendations says it should be done only when proven fertility preservation methods such as oocyte, embryo, or ovarian tissue cryopreservation are not feasible, and in the settings of young women with breast cancer. So it is not a preferred method. It is done in patient. It is supposed to be done in patients where you are not able to do the standard treatment. GnRH analog may be offered to patients in the hope of reducing the likelihood of chemotherapy-induced ovarian insufficiency. Ovarian insufficiency symptoms, as we ovarian insufficiency, some symptoms it can mask for some time. Insufficient evidence regarding their effectiveness as a fertility preservation method should not be relied on to preserve fertility, as earlier explained. Now coming to the treatment options for males, very important one is sperm cryopreservation after masturbation, sperm cryopreservation after alternate methods of collection, testicular transposition, as I said in females, ovarian transposition, here testicular transposition, testicular suppression, testicular tissue cryopreservation, testicular gonadal shielding during radiation therapy. So for adult males, present sperm cryopreservation technique is the only established fertility preservation methods. So this is the best we can do. The very important point here is, as I said, oocyte cryopreservation or embryo freezing is very important tool, and it should be done as early as possible. The same thing applies. The semen cryopreservation should be done as early as possible, and before starting any of the chemotherapy or radiotherapy, even single cycle or single exposure can damage the sperms to a very high extent. Hormonal therapy is not recommended, not successful in preserving fertility. Testicular tissue cryopreservation does not require, as I said with ovarian tissue cryopreservation, this also does not require sexual maturity for the purpose of future reimplantation or grafting of human testicular tissue. Experimental potentially higher risk of genetic damage in sperm collected after initiation of therapy. As I said earlier, that even single cycle of cytotoxic drugs or single exposure of radiation therapy can damage the sperm very badly. Special considerations for children, post-pubertal children. The established post-pubertal children means that the patient has, the children has attained puberty and the eggs and the sperms are mature now. In these cases, established methods of fertility preservation is semen or oocyte cryopreservation with parent or guardian consent. Pre-pubertal children, the only free fertility preservation options are ovarian and testicular cryopreservation, which are still investigational. Conclusion: fertility preservation is often possible in people undergoing cancer treatment. It must be considered before starting cancer treatment. Broader application is limited by several factors: lack of knowledge, lack of insurance. Lack of insurance is very, very important. Failure to, because the patient, they themselves are broken with the expenses of cancer treatment, and adding a new thing, fertility preservation, sometimes they have to prioritize that what is more important. So they in most of the cases they always want that we should spend all the money, most of the money on cancer treatment and not on infertility, fertility preservation procedures. So lack of insurance also is a very important factor, as these days many of the insurance companies are now coming for IVF treatment, coming forward. So hope to see more companies coming in future for fertility preservation options as well. Failure to discuss options, as I said, that we are so disheartened, the family is so disheartened, the diagnosing doctor sometimes also is so disheartened by the cancer thing itself, that we miss out on points like uh, fertility preservation. Investigational status of various fertility preservation methods. Yes, there are investigational status, but there are methods like oocyte cryopreservation, sperm cryopreservation, embryo cryopreservation. These are very old methods, very genuine methods, and it has been doing wonders. Fertility methods are applied infrequently. Many methods are still in experimental to be performed at recognized centers only. This is a very, very important point, because these preservation strategies need very high-end labs and very important equipments and the handling person. So it should be done at recognized centers only. Patients interested are encouraged to enroll in clinical trials that will advance medical knowledge. So wherever we have reached now is because of these clinical trials only. So we need to encourage our patients to participate in these clinical trials. Counseling of cancer patients must include fertility preserving options. Timely referral to appropriate specialist is very, very important.